as I was saying, it's my absolute pleasure and pleasure of Julie's, my co-presenter for today, to bring this webinar to you. We are thrilled to be spending an hour together talking about intervention. And one of the reasons why we are talking about intervention is because back when we think about originally when trying to give shape to the function of the healthcare interpreter, there's always been some sort of dichotomy that has been centered on two different perspectives regarding what limits interpreters can have as part of their role, as well as what sort of relationship the interpreter should have with both the patient and the provider. So one of the two perspectives is usually seeing the interpreter as a neutral and an uninvolved party versus the other perspective that sees the interpreter as this active and engaged individual who has a variety of functions and behaviors. So let's go back to the neutral interpreter perspective, and according to that perspective, the sole function of the medical interpreter is to facilitate the message, and the interpreter's only responsibility in the encounter is really to provide accurate and complete transmissions of messages that are conveyed from one language into another language. And by doing so, this keeps the interpreter as invisible as possible, thus allowing the patient and provider to interact as nearly as possible as if they were engaging in the same language. Now, this perspective doesn't see the interpreter, therefore, as an active player in the social encounter that occurs between the patient and provider, but it sees the ideal interpreter sort of as an unobtrusive and non-relational interpreter. Now, in contrast to this perspective, the other view, which is the active interpreter perspective, let's call it, for lack of better words, sees the interpreter as someone who is likely to hold a variety of responsibilities of simply passing the message, in other words. So this perspective truly incorporates the idea that since the interpreter is often a part of the patient's cultural context, or at least has some better knowledge of that context than a provider does, or also has some level of knowledge of the provider's context as well, this knowledge then becomes key to understanding the intended meaning of the message that is believed to be conveyed, in order to make the appropriate equivalent conversions. So therefore, this knowledge really allows the interpreter to sometimes assume an active role in the clinical encounter, allowing the interpreter the opportunity to interject between the patient and provider. And this is actually a perspective or an idea or a stance that was further solidified in a book written by Claudia Angelelli. If anybody here has read the book, is titled Medical Interpreting and Cross-Cultural Communications, where she, based on her study of a number of medical interpreting encounters in California, she observed that interpreters were conducting themselves almost as co-constructors of the interaction rather than being these invisible and neutral interpreters. Oops. And one moment, I'm trying to, okay, here we go. So therefore, this non-neutral but rather active role, oops, let me go back, I think I skipped one slide. This non-neutral but rather active role that is then assumed to convey what the parties intended to say requires some coordinating functions, such as, for example, clarification, prompting to explore or explain that one party might not be understanding something, and it takes shape in the form of what is known as an intervention. So in other words, anytime that we need to clarify a word or a concept, or anytime that the interpreter may feel the need to explore or prompt to explore the cultural context to avoid any misunderstandings, then the interpreter will be stepping out of the message converter role for a moment, and in which the interpreter is only passing the message, so to speak. However, we also need to keep in mind this. Every time, well, let me actually back up. Interventions are obstructive, and they interrupt the flow of the communication between patient and provider. So that's something that we always need to be very mindful and very aware of as interpreters. Therefore, intervention should be done, but when absolutely necessary. And so, speaking of the interpreter's role, let's just very quickly review some of these. As you may remember from previous training that you may have received based on the CHIA standards of practice and code of ethics, the function of the interpreter identifies 4 main roles, one being the conduit or message converter role, the message clarifier role, the cultural clarifier role, and the role of advocate. And based on what I said just a moment ago about the active role assumed by this need of clarification, clearly this points to the fact that both the message clarifier and the cultural clarifier roles requires these interventions. So again, as you may remember from your previous training, the conduit or message converter role is really the safest of the roles, since as a conduit, the interpreter's responsibility is really to maintain meaning accurate and complete when passing the message from the provider to patient and vice versa. And by doing that, the interpreter does not omit or add or changes anything from the intended meaning or the intended message. Now, this is accomplished by not only maintaining the meaning that is embedded in the words, but also the meaning that is embedded in the spirit and the tone of how those words are conveyed. So another thing that is very important to note is that we need to remember that in order to become the voice of the provider and the patient, then we will be passing this message using the first person. As a message clarifier instead, the interpreter identifies words or concepts that may lead to misunderstandings, perhaps due to dialectal differences or medical jargon. And then the interpreter is able to assist in clarifying them for both the patient, the provider, and for the interpreter themselves as well. So the interpreter here is also able to coordinate functions in order to prompt verifying understanding whenever the interpreter may feel that there may be some confusion or perhaps there is ambiguity that may exist in the message. On the other hand, with the cultural clarifier role, this role goes beyond the message clarification, as what it does is it empowers the interpreters to really interject, to be able to clarify or prompt exploring cross-cultural differences that may be causing misunderstandings. So think, for example, of the many words that do not have a linguistic equivalent due to the cultural framework of the U.S. health system, such as, for example, the role of a nurse practitioner or even a physician assistant, which is absent in multiple cultural frameworks of healthcare systems outside of the U.S. So, think about also the different expectations that patients and providers have during an encounter, perhaps due to their culture and personal values, such as the simple concept of how much time is appropriate to spend with a doctor during a medical exam. And then the repercussions when these expectations have not been met. And then, of course, we have the advocate, the patient advocate role, which this is a role that is not usually used in high-stakes situations. That's why we like to portray the imagery of a stormy weather. And this is a role that we take on when the risk of intervening to advocate outweighs the risk of not intervening, such as, for example, when the patient's well-being is in danger or potential harm due to perhaps human error or due to discrimination. And because of the complexities that are involved in this role, this is usually suggested as an optional role to be used at the discretion and careful judgment of any experienced interpreter. And so now that we have briefly revisited the interpreter's role, my co-presenter Julie will walk us through some of the basic reasons for an intervention. And Julie, I'm going to pass the mic to you.
Good morning, everybody. It's really a great pleasure to be here with you and with my colleagues Rosanna and Michelle, and I hope you're all doing great and enjoying this. So thank you, Rosanna, for that wonderful introduction. And I just wanted to mention, in case you were wondering why we had this nautical theme, Michelle had mentioned that this webinar occurred in Long Beach. It was actually on board the Queen Mary, hence all the ship metaphors, in case you were wondering. So, starting off from what Rosanna was saying about the different roles of the interpreter, and basically when we step out of that primary role as the message converter, what we are doing is intervening in that basic message when we switch to other roles. And there are a number of different situations that might trigger the need for the interpreter to step out of the role of the message converter. And we've divided those into 4 broad categories. The first one we could call linguistic category. So any challenge to do with the language, the words that either the provider or the patient is using. It could be, for example, that the patient is from a different country than you as the interpreter from and uses a word that you might not be familiar with. Or the provider might use a term that is unfamiliar to you that you might need clarification on. And it also could have to do with actually listening conditions. You might be working in a busy hospital and there might be an overhead page or a code blue or some other alarm system going off, or perhaps the patient might be speaking somewhat incoherently or might have a type of speech impediment, or the provider might have an accent that you're unfamiliar with. So anything to do with the actual language and the words and the verbal aspects of the message are the first type of challenge that would cause you to intervene in order to clarify so that you could interpret accurately. The next type of challenge or situation that could trigger the need to intervene are what we call role confusions. And I'm sure you're all familiar with that when someone, either the patient or the provider, asks you to do something that's actually outside your scope as an interpreter. So what are some examples of that? Well, for example, the provider might ask you to go over the site consent with the patient while he or she steps out of the room. And as you may remember from your training, that is something that's definitely outside our scope, as we need the provider to be present to address any issues and answer any questions that the patient might have. Or another example of role confusion might be that the patient turns to you and says, do you think I should have this surgery? That actually happened to me when I was doing telephonic interpretation, and the provider stepped out of the room to go get the informed consent document, and the patient, who had never met me or hadn't even seen me because this was not video, it was simply telephonic, said to me in Spanish, Oiga, señorita, miss, do you think I should have this surgery? So this is something that unfortunately is common, and again, we would intervene in order to clarify to whoever is asking us to do something outside our scope to clarify our role. Now, this role confusion can be avoided with a good pre-session in which you lay out, how the session will go, and you explain that everything will be interpreted to both parties. And but I understand that we don't always have the ideal conditions, and it's not always possible to do a full pre-session. So we still might end up with this kind of role confusion. The third type of situation that could trigger the need to intervene are cultural misunderstandings, and that probably is something that also is fairly common, at least in my experience. I work in California, and we have most of the population I interpret for from Mexico, but we also have residents from other Central and South American countries. And many of the traditional healing practices that they might be utilizing in conjunction with seeing a doctor might be unfamiliar to the provider and might trigger the need to alert the provider or encourage the patient to provide more information about that traditional healing practice. And the cultural misunderstandings obviously can work in both ways. If there's something about the U.S. medical culture that the provider might assume the patient understands. For example, the whole informed consent process, where not everyone is used to hearing all the possible risks that might happen from a surgical procedure, for example. So then these cultural misunderstandings obviously would trigger the need to intervene as a cultural broker, cultural mediator, cultural clarifier. And then finally, the fourth type of barriers are more of the systemic barriers to do with discrimination or perhaps a medical oversight that would trigger the need to intervene in the more expansive and tricky role of the advocate. So just to summarize then, these are four broad categories of the types of situations that would trigger the interpreter to step out of the primary role as a message converter into one of the other roles, either a cultural clarifier, or the advocate. So as Rosanna explained when she was going over the roles, the message converter role is the primary role for a very good reason, and that is it is the safest role, and it has the least potential for disrupting that therapeutic relationship between the provider and the patient, which is also the primary there to support. So a good rule of thumb is basically not to intervene unless we can assess that the potential consequences of not intervening exceed the risks of intervening. I think I'll say that one more time so we can all wrap our heads around it. So the rule of thumb is do not intervene unless the potential consequences of not intervening exceed the risks of intervening. Now, that sounds straightforward, but when you are trying to make a decision on the spot in the moment, it's not so easy. So there's some things that you can do kind of to think through the possible scenarios that would require this so that you have a basis for making that type of decision on the spot. So in order to illustrate how to intervene effectively, we are going to call upon our friends here. If I can find my right screen, one moment. And we're going to have a little demo skit, and Rosanna will be our provider and I will be the interpreter. And I'd like you to notice how this goes, and then we'll have a chance to debrief it and see how our little friends here did. So go ahead, Rosanna. Rosanna?
Yes, I had my microphone on mute. Okay, sorry about that.
Doctor,
Right.
I've already introduced myself to the patient, so please go ahead.
Well, I understand that you've tried physical therapy, steroid injections, and pain medication for your back pain with no success. And I think you are a good candidate for a trial of a spinal cord stimulator.
Whoa, Doc, slow down here. I'm totally lost. Could you maybe, dumb it down a little? Okay, so what do you think? Was that a smooth intervention? I don't think so. So what are some of the things that went wrong there? We probably could make a whole list, right? So the interpreter did not stay cool, calm, and collected. She pretty much fell out of the boat and had to be rescued, I think. So the interpreter, the first mistake she made is that she did not interpret anything of what the provider said. And what was actually tripping her up was the last phrase, the trial of spinal cord stimulator. So she should have interpreted the first part of what the doctor said, which was what the patient was waiting for her. And when she then needed to clarify, she should have identified herself as the interpreter. And there's a few different ways you can do that. For example, excuse me, the interpreter would like to clarify, or the interpreter needs clarification, or speaking as the interpreter. So once she had identified that she was stepping out of her primary role, then she would have briefly intervened with one party, let's say the provider. Excuse me, the interpreter would like clarification of trial of spinal cord stimulator. This way, the interpreter isn't asking the doctor to clarify the whole message, only the part of the message that the interpreter did not understand, which will save time and keep the intervention briefer, which will enable us to get back to the primary role of converting the message. The interpreter should have also interpreted that message to the patient in order to be transparent, so the patient would know what this side conversation was about. So in the target language, the interpreter could say something like, the interpreter asked the doctor to explain the term spinal cord stimulator. Now, these last two points can be done in either order. You could first turn to the patient and say briefly, the interpreter needs clarification, and then turn to the provider and ask the clarification. The important thing is to be transparent so both parties know what is going on. And then finally, the interpreter should have interpreted the message to the patient, incorporating the provider's explanation, and then slipped back into interpreting and the message converter role. So this would have been a much ideal scenario and would have prevented this boat from capsizing. So now Rosanna is going to summarize for us and tell us what, go over again these main points just so we're all clear on them.
Thank you, Julie. So yeah, let's review again the order of these basic steps for intervention. Remember that our basic role, like Julie mentioned, is to interpret everything that is said, which is here our first step in the intervention. Even if you do not recognize a word or a concept, in which case you may leave the unrecognized words or words in English or in the target language, whatever the case may be. Next, in order to intervene, we need to step out of that conduit role, which means we need to stop using the first person and identify ourselves as the interpreter to avoid any confusion about who is speaking during the intervention. And also, we need to intervene. So we will intervene by stating the need for the interpreter to intervene, perhaps to clarify a word or a concept, or perhaps to ask the provider or patient to repeat what was last. And then one of the things that Julie beautifully said was the importance of maintaining transparency. And we will maintain transparency to alert the other party about our need for an intervention. And then once we have taken those steps, and again, the 3 and 4 can be reversed, the order may not be exactly the same. And the most important thing is that once we have completed the intervention, we resume our interpreting. So here is our first trivia of the day. I'm going to read it to you. Please indicate what best describes from the options below the reasons for triggering the following intervention. Provider is asking interpreter's opinion on whether patient seems confused. Is it a cultural misunderstanding that is triggering the need for intervention? Is it a linguistic challenge? Is it a role confusion or role boundary issue? Or is it a service system barrier issue? And I'm sure
I'm going to go ahead and launch the poll and give our attendees an opportunity to, vote on their choice here.
Okay.
What they think is happening. Okay, so it looks like everybody who's going to vote has done so. So
all right.
we've got role confusion and role boundary as the leading choice here, followed by linguistic challenge and then cultural misunderstanding.
Okay, very good, very good. Thank you. And we will definitely we'll be happy to address these at the end in the area, the question, frequently asked questionnaire. Wonderful. Well, wonderful. So now that we have done this little trivia and that we have reviewed this suggested order of steps for an intervention, let's see how these unfold in action when done the correct way. So here we go again. We're going to have our animated little friends who are going to, once again, enact the intervention. So I understand that you've tried physical therapy, steroid injections, and pain medication for your back pain with no success. And I think you're a good candidate for a trial of a spinal cord stimulator.
I understand you've tried physical therapy, steroid injections, and pain medication for your back pain with no success. Excuse me, the interpreter needs clarification. Doctor, the interpreter needs clarification. What is a spinal cord stimulator?
Well, of course, a spinal cord stimulator is a device that is surgically placed under your skin to send a mild electric current to your spinal cord.
Thank you. I think you're a good candidate for a trial of a spinal cord stimulator, which is a device surgically placed under your skin to send a mild electric current to your spinal cord.
All right, here is another trivia for you. Choose below what you think should be the first step for an intervention. Is it to be transparent and inform the other person what you said during the intervention? Is it to intervene briefly? Identify yourself as the interpreter? Go back to interpreting or interpret what was just said? And Michelle, I think you're probably going to switch, correct?
Yes, that's correct.
Okay.
And it looks like we have everybody has voted now for this particular poll question. So I am going to go ahead and reveal the results. So we've got most everybody saying identify yourself as the interpreter, followed by interpret what was just said and be transparent. Intervene briefly, got a couple of responses, and nobody chose go back to interpreting.
Okay, well, that's a good sign. So back to the take two that we showed, the second part, where the interpreter did follow the correct steps for intervention. Did you sense that the intervention went smoother that time? Did the interpreter indeed follow the suggested steps for interpreting what was just said, even if the message contained a whole string, a whole concept that needed to be clarified by the interpreter? Was the interpreter clear on what needed to be clarified during the intervention? Did she identify herself, and was she transparent with the patient? Remember the importance of transparency, especially maintaining trust. And then finally, did she go back to interpreting as soon as the intervention was completed? Okay, and Julie, I'm going to hand over the mic to you.
Okay. Thank you, Rosanna. So we seem to have a common theme here about falling overboard, and indeed our intrepid interpreter did fall overboard the first time, but hopefully not the second time. So we wanted to summarize a few steps that you can take as the interpreter so you don't fall overboard. So it's a really good idea, as with anything in life, to plan ahead, and we might want to think about ahead of time what we're going to say when we intervene, not the specific words we're going to use to clarify a specific situation, but rather the general words that we're going to use when we intervene and step out of our primary role. Otherwise, what might happen is that we might be caught like a deer in the headlights. which is an expression that means your mind goes blank and empty. And I know that that's happened to me, and I imagine it might have happened to you too, when you're in those situations and you know you need to intervene, but nothing comes out, right? And that in turn makes you feel nervous, and you might end up saying something long or complicated or get into a side conversation with either the provider or the patient, which would obviously disrupt the flow of the communication and disrupt that primary relationship between the patient and the provider. So one way to avoid this is to create what we call mental scripts. And if you could forward the next slide, Rosanna, thank you. And a mental script is something that enables you on the spot, when you're right in the middle of the action, to be brief and clear in your intervention, to precisely identify the problem so that you are not asking the speaker a vague question about clarifying that would then entail them losing track of what they were saying and giving you a long-winded answer, and also sounding polished and smooth and professional. So mental scripts are something you can have in your toolbox that will really make it a lot easier for you to be able to intervene in a way that's smooth. So what we're suggesting, and what we did in our workshop, is to allow you some time to create your own mental script so that you can intervene in a variety of different situations. So there might be a script for when you need to clarify a word or a concept that the doctor used that you do not recognize. So that would usually be in English, and then in your target language you would want a script for how you would intervene. That is to say, what are the exact words you would use to clarify when the patient uses a word or a concept that you do not recognize because you're from a different country. For example, my friend Rosanna just gave me a good example. Avocados, one of my favorite foods, are paltas in Argentina. And if a patient said that to me, if I didn't know that beforehand, I would need to clarify because I know them as aguacates. Another example of a script would be when you suspect the patient is not understanding and you want to verify that. We don't want to assume a patient is not understanding, but sometimes the patient might give us some nonverbal cues or even linguistic cues that would indicate that they are not understanding, and we would want to verify that and alert the provider to that. So what words would we use to intervene in that manner? And then another type of script would be when we want to intervene to prompt the doctor that there might be some cultural values that are creating a communication bump. For example, we might detect that the patient is seeming very distressed if the provider is discussing end-of-life issues with a relative, for example, or with informed consent when the provider is describing in great detail all the possible risks, including death, that might occur as a result of a procedure. So these are all the kind of scenarios where if we have a mental script ahead of time, we will be in a much better position to do a brief, smooth, professional intervention without getting off track. So in order to do that, and before we do that, I'm going to give you some examples of the phrases that you might use. And again, these are just examples because I think it's important for you to find the words that come naturally to you that you will feel comfortable using, either in English or in your target language. So, for example, excuse me, the interpreter recommends, or the interpreter is concerned that, or excuse me, the interpreter requests clarification of the term, the interpreter needs to, the interpreter asks the provider to clarify, etc. So these are all examples of some of the words that you might use. And again, you want to choose what feels normal to you and what will come naturally to you. And I think it's time for another little trivia quiz. And here is our perplexed face to indicate that. So this question is, please indicate what best describes from the options below the reason for triggering the following intervention. The patient is using a dialectical word that you, the interpreter, do not understand. Is that a question of cultural misunderstanding, linguistic challenge, role confusion, or a service system barrier?
So it looks like overwhelmingly people have said this is a linguistic challenge and followed by a cultural misunderstanding. Nobody has chosen role confusion or service system barrier.
Thank you, Michelle. And again, we will have the opportunity to discuss this at the end when we have our questions and answers. And now what I'd like to do, if you could advance the next slide, Rosanna, is give you a few minutes to create your own script for one of those situations and actually take a moment and write it down and say it out loud. And I was going to say you could even record it on your iPhone, but then you might get distracted by Facebook. So let's just keep it to writing out a script for one of those scenarios to clarify either a linguistic challenge, a cultural bump, a role confusion, what you would say in English, and then one in your target language, and then just read it out loud to yourself. So it is 10:50. We will give you 3 minutes till 10:53 to write your scripts, and then we will have an opportunity to hear from you how that went when we have our Q&A. Okay, that's about 3 minutes here. I hope everyone had a chance to think about a script that they might want to use and write it down in both in English and your target language, and to let it roll off your tongue and see what it sounded like.
So
I'm going to pass it over to Rosanna again, who's going to show us how to bail our boats out.
Well, hopefully, right? Well, I really hope that you all had, I know that we didn't have much time available as we would have wanted, but we hope that at least that gave you a chance to, if anything, write even just one script, perhaps if you were very good, 2 or more. And these scripts hopefully will be come in handy in times of need. We also hope that you had a chance to practice them out loud, and especially since you are in the comfort of your home or your office or wherever you may be right now. But I want you to share with us, perhaps at the end of the presentation during the Q&A session, whether any of you felt that you had a moment where you stalled or stumbled as you were practicing out loud your script. And of course, you know, practice makes perfect. Think about that. So again, we cannot emphasize enough how useful it is to feel prepared ahead of time, just like Julie, my colleague Julie was saying, because by having just a simple script prepared, a mental script to help you guide when you need to step out of the message converter role and make your intervention, it will help you make that intervention smoother, and it will help to make you sound professional, and also it will make you assertive about your role, and it will help ultimately to build trust with both patient and provider. So remember that unlike the advocate role, which is suggested to be as an optional role, the message clarifier role and the cultural clarifier role are seen as essential functional roles in order to maintain accuracy and completeness. Now, this means that if you opt out to intervene when you may not understand a word or a concept, you will more likely be leaving information out, or you will more likely be skewing the meaning from the original message, and possibly edit the message in ways that will add stuff or information that was not part of the original message to begin with. So these are the typical errors that we see interpreters or ad hoc interpreters make. These were indeed the kind of errors that were observed in incremental numbers, particularly when using ad hoc interpreters or friends and family members as interpreters in a study that was conducted by Dr. Flores and a few of the co-authors back in the mid-2000s. The name of the study was called The Impact of Medical Interpretive Services on the Quality of Healthcare, a Systematic Review, Medical Care Research and Review. So, with that being said, oops, and there's still some animation going on here on the side, but we wanted to summarize with you, to sum up really what we have talked about today. Intervening is the interpreter's act of interrupting a session in order to remove a barrier to communication. Hence, it should be done when absolutely necessary to maintain accuracy and completeness of message or to ensure understanding.
Intervening is a potentially risky action that could capsize your boat. So when in doubt, stay out.
And determine whether the consequences of not intervening outweigh the risk of intervening. Remember that if you're going to make an unnecessary intervention, you may be causing some frustration by interrupting the flow of communication between patient and provider and possibly hinder their interaction.
And if you do decide to intervene after weighing those consequences, remember to keep your intervention brief and professional. And the best way to do that is to practice beforehand what exactly you are going to say in a different variety of situations so that it will come out easily and smoothly, and you can maintain that brief, professional, and smooth interpretation and intervention. And finally,
and last but not least, yeah, always go back to interpreting in a seamless way. I mean, that is really the basic function that we have, and that's why we are there with the patient and the provider, after all. And we are there to interpret, we are there to facilitate communication. And with that being said, Julie and I want to thank you so much for spending an hour of your day today with us to go over this information. Julie, I'm going to leave the mic back to you to say anything that you wanted to add.
Thank you, everyone. Well, we wish you smooth sailing in your interventions from now on, and we now have a nice chunk of time to go over questions and answers and discuss the survey results and some of the different choices we made in answering that. So, Michelle, if you would be so kind as to share some of those questions with us, and then we can talk about them.
Sure. I haven't seen any questions come up yet, so I just want to remind everybody to please post your question, whether it's regarding the polls or any of the other information that Julie and Rosanna have shared. But to get us started, one of the things that occurred to me that I wanted to ask if you could clarify is when you are saying that to identify as the interpreter, can you describe what you mean, the difference between introducing yourself as the interpreter and identifying yourself as the interpreter?
Oh, sure. So,
part of that first poll question that I wondered when it was asking what is the first step, and I'm wondering if there may be confusion about what the difference is in those.
That's a really good question, and I could see that would potentially be confusing. So I think when we say introduce ourselves, we're perhaps talking about in our pre-session when we greet both the patient and the provider and we tell them our name, the agency we're with, explain our role, assure them of confidentiality, let them know that we will be interpreting everything that is said and that we will be speaking directly as the voice of either the provider or the patient. So that, I think, is what we mean when we say introduce ourselves. So we're really laying the groundwork with our pre-session as to how we will be playing out our role. And then when we say identify ourselves, because as Rosanna explained when she was talking about the different roles of the interpreter, the standard of practice for professional interpreters is to use the third person, so that, for example, when the patient says, my stomach hurts, the interpreter says, stomach hurts, instead of saying, she says her stomach hurts. So when we are going to speak in our own voice as the interpreter, we need to switch out of that first person mode and identify that it's us, the interpreter, speaking. Hence, we would refer to ourselves in the third person, which is why we would say something like, the interpreter would like clarification. Because if we said, I need clarification, because we have been speaking in the first person, the person that we are directing ourselves to might assume we are still speaking for the other party. So I hope that's clear. I don't know if you want to add anything to that, Rosanna, but basically the identifying ourselves as interpreter is when we switch from that first person to the third person so that both parties know that it's the interpreter speaking in his or her own voice instead of in the patient or the provider's voice.
And I can't add anything because that was beautifully said. Again, just to sum it up, introduce the interpreter, think of it as a pre-session, identify the interpreter, think of it as when stepping out of the message converter role.
Perfect.
Thanks for the great question, Michelle.
Sure. And so we do just have a general question about reviewing the polls and providing the answers to those.
Mm-hmm.
Great. Can we put them up one at a time so we can talk about each one?
We can. If you give me just one moment here, I'll pull them up.
I believe, Michelle, you have mentioned that there was a question regarding the answers, the correct answer for the first trivia question, which addressed the provider asking the interpreter's opinion on whether patients seem confused.
Correct, yes. And I've put that back up on the screen now.
Oh, excellent. Beautiful. You're so many steps ahead of me. So with this, and Julie, you don't mind if I take over for this?
No, go
okay.
for it.
All right. So for this particular example here, the provider is asking the interpreter's opinion on whether patient seems confused. And remember that one of the from your previous training on CHIA standards of practice and code of ethics, you might remember one important concept, which is the one principle, which is the principle of the impartiality, which helps us reduce any involvement from the interpreter's side into the encounter between the patient and the provider. Yes, we do have this opportunity of this function of more of an active role by doing the intervention, but we don't want to extend that active role to the extent of putting our own voice into the encounter. And so sometimes this is a perfect example of when providers who may still not have a full understanding of what we can and what we can't do as interpreters and what our role is as an interpreter, confused and about the boundaries that we have to respect. And so by asking our opinion, it's not really up to us to provide an opinion on whether the patient seems confused. That requires some subjective response, and that is not really what we ideally want to be as an interpreter. We don't want to provide a subjective opinion of whether the patient is confused or they may be lying. This is another one, and again, this is something that may come up over and over. It's pretty frequent, believe it or not. It's happened to me several times. I'm sure it's happened to some of you, and I know it's happened for sure to my colleague Julie, where the provider is relying so much on the interpreter at some point, and my colleague Julie was actually bringing the reverse situation when she was talking earlier in some of her talk points about the patient asking the interpreter to help them make a decision, for example. It's the same exact situation. It's that role confusion of relying and trusting the interpreter to beyond what the actual boundary of what we are allowed to do. So again, this particular trivia here portrays a perfect example for role confusion and role boundary.
Rosanna, thank you. That was a great answer. I don't really have much to add. One thing perhaps that would just occur to me as you were talking is that, and this is something I've used in a few different situations, that obviously something is going on in this situation where the provider is feeling lost. And even though, as Rosanna very correctly points out, we cannot give our opinion, we can offer to assist the provider to clarify that by suggesting, for example, is there something you would like to ask the patient that I could interpret for you? Or perhaps you might want to ask the patient if they are understanding, or the interpreter might like to suggest that you ask the patient to explain what he or she understood you to have said. So there are things that we can do that maintain our ethical boundaries and that don't provide a subjective opinion, but we can offer suggestions or recommendations to the provider in this case to help them sort out that confusion themselves using us in our primary role as the interpreter.
Thank you for that
Excellent.
comprehensive answer. And I will go ahead and move on, let's see here, to the next one that we did. And I believe it was this one. This may have been the second or the third one.
Oops, sorry. Michelle, I think I clicked on the PowerPoint, and I believe at this point the screen is showing the PowerPoint.
We should have the poll up now.
Yes,
Oh,
we do.
Okay. I don't
It
see
did
it
flash to
online.
the PowerPoint just briefly, but now we're on to the poll question.
Okay. I don't see it on my screen, but perhaps it's only on my end. Hopefully it will be only on my end. Okay.
So this
So shall I read it if you don't have it?
because I don't see it. Yes, please.
Sure.
Thank you.
So indicate the first of the suggested steps for the intervention below. So the options were be transparent, inform the other person what you said. We had 13% of respondents choosing that one. Intervene briefly, we had 3%. Identify yourself as the interpreter, 55%, so that was definitely the majority. Nobody chose go back to interpreting, and 29% chose interpret what was just said. So we did have a clear majority expressing the thought that the first step should be identify yourself as the interpreter, followed by 29% with interpret what was just said, and 13% be transparent, and then 3% intervene briefly. So I think the answers, the variety of the answers, even though there is a clear winner, you could say here, correctly so, with identifying yourself as the interpreter, is that I do believe there is a little flexibility in the steps of intervention in terms of interpreting what was just said and then intervening, or intervening and then interpreting what was just said. And I think that really depends on the situation, on the length of the utterance, whether, for example, the part that causes the interpreter to stumble is at the beginning of what was said, then obviously the interpreter couldn't just interpret what was just said because they would need to intervene in order to be able to interpret. So I think there is some flexibility there in terms of that particular order. I don't know if you would like to add anything to that, Rosanna?
Yeah, no, really not much, except that again, we offer you the suggested order as a guideline, but please always remember that life happens, and what we talk about in a classroom setting doesn't always reflect what happens in real life, and we need to always be flexible. And one of the possibly the most important skills as interpreters is to be really a strategic thinker, which is something that unfortunately is not always very strongly addressed in trainings, but we are constantly strategically, because we don't have much time to things. We have to come up with solutions in a very short span of time. And like my colleague Julie was saying, we have to maintain that flexibility depending on the given situation. We don't want you to think these are just suggestions in terms of the orders of the steps for interventions to give you some sort of guideline. But we don't want you to feel, oh my God, I need to do this first. Oh, I forgot to do that first. Oh, darn it, I screwed up here. We don't want you to feel stressed about this. We want you to feel very comfortable moving through these steps in a way that is very flexible and that you can adapt to any given situation that you find yourself in.
Excellent. And let me go ahead and show them the last poll question that we had here. Patient is using a dialectical word that you, the interpreter, do not understand. And we had the majority of the attendees said this was a linguistic challenge. A few said this was a cultural misunderstanding, and nobody chose role confusion or service system barrier.
Well, I think that one pretty much speaks for itself, at least in the language that I interpret in, which is Spanish. As I mentioned earlier, we have many different countries around the world that speak Spanish and many different regionalisms as well. So it's very common to hear a word that you might not be familiar with, and I'm sure that's the case in many other languages. And I think I can understand the choice for cultural misunderstanding because a lot of words might be symbolic of a cultural construct. For example, I'm thinking of some examples in Spanish again, and I'm sorry, that's my only example. Perhaps Rosanna can share one in Italian. For example, the term empacho or a sobadora. Empacho is, for example, it's a situation where you eat something and it is believed to be stuck somewhere in your intestine. And one of the ways to address that is with a sobada, which is a vigorous kind of intestinal rubbing that will help move that stuck bolus of food. So that would be a good example where it is a linguistic challenge, but there's more to it than a simple word because there's a whole cultural construct that's involved in that particular word. We'll leave it to my colleague Rosanna to see if she would like to expand on that.
Yeah, no, and I agree. I mean, I think when we put together this particular question, it was what we both, Julie and I, had in mind was really the dialectal differences that may exist. I think, for example, in the Arabic language as well as in Spanish, where depending where we may have grown up, they may be using different level of vocabulary, and somebody who speaks from Arabic from Iraq may have some dialectal interferences with somebody who speaks Arabic from Egypt or Lebanon. So same thing, likewise, it happens, the same thing happens with Spanish, or may happen with other languages as well. So we're thinking of those differences in dialect within the same language that sometimes create a confusion. One being, for example, the one that my colleague Julie was using, that we exchanged earlier today about the palta, the avocado, which is a word that I use very frequently. That's actually the word that I grew up with using, and again, you know, it is really a linguistic dialectal word difference here, more so than a cultural misunderstanding. But again, I do agree with my colleague in the sense that there are some words that most certainly have a cultural nuance embedded in them, and therefore the clarification with those words will not be considered strictly linguistic, but it would be considered also cultural, as part of a cultural clarification due to those cultural nuances that are embedded in the meaning of the word. That's all that I wanted to add to that.
Great. So I think we've gone over our 3 trivia poll questions, and I hope you enjoyed participating in the polls. And I wonder if any more questions have come in the meantime, or...
Yes, we have had some questions and comments here. So here's a practical question of logistics, let's say. Our participant is wondering about an effective way of dealing with a common situation in which the patient will be speaking directly to the doctor for a while and then at a certain point start addressing the interpreter. So for example, say to the doctor, by the way, can, you know, all of a sudden they're speaking to the doctor and then say, can you ask the doctor if he can renew the prescription? So how do you deal with changes in the, you know, switches with the person to whom the patient is addressing? I suppose this could happen on the provider side too, and that's the practical question being asked.
That's a great question. Do you want me to answer that, Rosanna, or were you?
Sure,
Okay.
go ahead.
Yeah, it's a wonderful question because it does happen all the time, and one of the the best ways to avoid it, obviously, is with the pre-session in which we emphasize to the patient and the provider that they can address each other directly. But in spite of that, I think it's the natural tendency of a speaker to turn to the person that understands them and that they can communicate with. So it is very natural for it to drift into that. And there's a few different things that I like to do, kind of in an order of progressive intervention, you could say. One is to break my eye contact with the patient and direct my gaze towards the provider. That often is enough, and it's a fairly subtle reminder, because if I'm not responding with that eye contact, then the patient more naturally tends to revert back to the person who is engaging with eye contact. I can also use a simple hand gesture, and I'm sorry you can't see me, but kind of using my hand to kind of direct the patient to speak directly to the provider while I look at the provider. So that's often effective. And then, as a kind of more interventive approach, I could just slip in a brief reminder, something like the interpreter would like to remind you, or just to address the provider directly, or you can address the provider directly, just slip in a very brief verbal reminder. But usually averting the gaze and using a hand signal is enough to kind of remind and prompt the patient, especially if you have done the pre-session and instructed them to do that in the first place. I don't know if there's anything my colleague Rosanna would like to add.
No, that's it. Those are actually the three strategies that I was thinking about exactly. So yeah, beautifully enunciated. Yeah.
Thank you. Did we have another question, Michelle?
So just I think you've been, of course, talking about the advocate role. And so one of the questions is, in terms of intervening as an advocate, it depends on the judgment of the interpreter. So while one interpreter might choose to intervene, another might choose not to intervene. And is there a way to reconcile this with standardization? Is there a need for standardization in approaching this role?
Wow, that's a great question with a lot of different aspects.
It is. It is a very. Do you mind if I take over, Julie?
Go for it.
It's a very loaded question too, if you don't mind me saying. There are so many complexities with the advocacy role. I mean, think about what kind of an interpreter are you? And when I say that, obviously being an a staff interpreter, part of the workforce, will you to be more of an advocate because you are familiar with the policy and procedures of the organization. You have a whole series of leadership that backs you up in your decisions and supports you. That might not be the case if you are interpreting in a hospital as a representative of an agency, where you may not really necessarily know what organizational policies are addressing patient advocacy, and how to navigate a lot of the issues that are addressed by patient advocacy. Should there be this standardization need for patient advocacy? It's of course, I think we need to have a little bit more clarity and more guidance for interpreters, because there is still a lot of confusion about, do I do it? Do I not do it? Am I an advocate? Can I step in? I'm not part of the workforce, and yet I have observed sometimes situations where it makes me want to step in, and I'm afraid that if I do, then I'm doing the wrong thing. So I think that one of the things, to my understanding, that the National Council of Interpreters in Healthcare is actually currently doing is that reworking or reviewing the standards, and one of the areas that they're looking carefully indeed that advocacy role, because there's so much controversiality around that particular topic. It'll be interesting what will come out when the National Council will have that process completed of reviewing the standards of practice and code of ethics. But again, I want you to know that it is exactly one of the areas that has been looked at very carefully, because it has been brought up multiple times, and it is probably one of the stickier areas of interpreting in terms of role and in terms of intervention as well.
Beautiful answer, Rosanna, and I think I don't really have a lot to add to that. I think the only thing I might want to point out to support what Rosanna was saying, I totally agree with that it's a very different position you're in as a staff versus a freelance interpreter. As a freelance, you definitely will be way more limited in your ability to advocate for a number of reasons, and also one of them being you simply aren't familiar with the protocols and policies as you would be if you were a staff interpreter of the location where you're interpreting. It's also important to know the policies of your workplace, because in many cases, someone who does function in that advocate role, and your role would simply be to inform the patient of the presence of this person, maybe take them there and interpret for them. But there might be somebody within the facility who already fulfills that advocacy role. And the final thing I just wanted to mention is that the CHIA standards has a beautiful section on an ethical decision-making process to help determine whether it's appropriate to advocate or not. And I think it's going to be, if we ever come up with we will probably come up with some kind of standard guidelines, but again, going back to what Rosanna was saying earlier about interpreters needing to think strategically and objectively, that we need to really have that tool in our toolbox to be able to go through a decision-making process that will really weigh the risks and benefits of intervening as an advocate or not in any given situation. And each situation, I think, is so unique. There's so many variables in terms of what's going on with the provider, what's going on with the patient, what's going on with that particular institution, the time and place that would affect your decision. So even though we do have general guidelines and policies, and I'm sure those will be further refined by the work of the National Council, it will come down to the interpreter's own ability to think strategically and objectively and unemotionally. I think that's another thing to keep in mind, that often the kind of situations where a patient might require advocacy can trigger an emotional reaction in the interpreter that can make us react in a way that is probably not in the best interests of the patient or the institution or ourselves as professionals. So that's part of why I think the CHIA ethical decision-making process is so valuable, because it really helps us to think through and break down all the different aspects involved so that we're really weighing the pros and the cons. Because as you might recall from one of those earlier slides when our colleague Rosanna was going through the different roles, the ship on the stormy sea is the advocate role. So hence it is such a loaded role. And that was a great question. I hope some of the thoughts that we both shared they're not going to give you a pat answer, but I think it's a very good question to be asking ourselves, and to really take the time before we are in those situations to go through that ethical decision-making process, which is available on the CHIA website. Am I correct, Michelle?
You're referring to the standards?
Yes, the standards.
Yeah. Yes, the CHIA standards, yes, those are available on the website. And just on that little note,
wonderful.
Yep, there is also on the YouTube channel one of our past webinars by Beverly Truman, who reviews those standards as well.
Great. So that's a really wonderful resource that I encourage everyone to make use of.
So we have just a couple of minutes left. This is probably our last question, and it is referring to the dialogue you had, the very initial role play that you were doing. And so the question was with regard to transparency. Is that not one of the first things to consider? Is that an acceptable consideration for that scenario?
Can you repeat the question again, Michelle? I just want to make sure that I'm understanding the question.
So what the attendee is wondering is, in that role play scenario that you had, where the provider was giving the information and the interpreter in the first scenario, of course, just right away said, hey, I can't, what's going on? I can't interpret this. And then, of course, you built on that. So the question is whether or not transparency is one of the first things that should be done from the interpreter's side as the intervention.
Well,
yeah.
Julie,
I think I see where that's coming from.
Yes, and yeah, I think that and that was left out on purpose, as a matter of fact. The lack of transparency in the first demo, where the interpreter did not follow the correct steps for intervention. Obviously, the lack of transparency was left out to demonstrate some of the wrong, some of the things that the interpreter should have done. But in terms of, I'm trying to understand if the person who's asking the question is, the question is really, should transparency come before anything else in the steps? And again, I think that we can go back to the answer that we gave earlier in terms of, we provide you with some suggested order, but how you can have your own flexibility in terms of, given the particular situation, if being transparent right away before you taking any of the other steps is what you deem most appropriate in that moment, absolutely, why not? Here to tell you, no, you can't do this or you can't do that. We're simply guiding you through some of the steps that will help you make that intervention in a smoother way, in a professional way, and in a way that doesn't break any trust, because transparency is really, really important. I mean, imagine putting yourself in the shoes of the patient who has no idea what is being said between the patient and the interpreter, sorry, the provider and the interpreter, and you're in a very vulnerable situation. And all of a sudden, you see that there's this side conversation happening, and you may be wondering if there's something that they're hiding, that they're not telling you, that they're discussing about you that is not being shared. So that's why that whole concept of transparency is so important, both for the provider and the patient, of course, is to maintain that trust. And remember that trust can go out the window between a patient and provider in a second. And if the patient loses trust, the chances are they're not coming back. They're not going to follow through with what the medical provider is giving them. So it's really, really important. I mean, we as interpreters and how we conduct ourselves can really make that we can strengthen that trust, or we can hinder that trust. And so that's why we want to give you some sort of base points that you can use to navigate yourselves through the intervention in a way that is successful and effective for everyone. But again, don't be very strictly sold on the exact order that we gave you with, because again, theory doesn't make practice all the time, and we have to adjust and adapt to any given situation that reality presents. I hope that answers the question that was the intention of the question, at least. And Julie, I don't know if you want to add anything.
Thank you, Rosanna. Yes, I think you gave a very full answer. I think the only thing I would add is that identifying yourself as the interpreter really is embedded in the concept of transparency, because what transparency is letting the other person know what you're doing, and as you do that, you are identifying yourself as the interpreter. So it kind of goes really hand in hand, because the words you use to be transparent, are the interpreter is asking the provider for clarification, for example. So I just wanted to throw that little piece in, that those steps are actually integrated together and embedded. I think that might solve some confusion too.
Well, thank you so much for that clarification and for answering all these wonderful questions from our participants. And I want to thank you both, Julie and Rosanna, for joining us today for the CHIA webinar.